Hello, and welcome to Conversations from the World of Allergy, a podcast produced by the American Academy of Allergy, Asthma, and Immunology. I'm your host, Dave Stukas. I'm a board-certified allergist and immunologist and serve as a social media medical editor for the Academy. Our podcast series will use different formats to interview thought leaders in the world of allergy and immunology. This podcast is not intended to provide any individual medical advice to our listeners. We do hope that our conversations provide evidence-based information. Any questions pertaining to one's own health should always be discussed with their personal physician. The Find an Allergist search engine on the Academy website is a useful tool to locate a listing of board-certified allergists in your area. Finally, use of this audio program is subject to the American Academy of Allergy, Asthma, and Immunology Terms of Use Agreement, which you can find at www.AAAAI.org. Today's edition of our Conversations from the World of Allergy podcast series is targeted towards Academy members, allergists and immunologists, and anyone interested in learning more about contact dermatitis. Today's guest is Dr. Marcella Aquino. Dr. Aquino is an associate professor of pediatrics in the Division of Allergy and Immunology at Hasbro Children's Hospital and the Warren Alpert Medical School of Brown University in Providence, Rhode Island. Dr. Aquino has a unique clinical and research focus on allergic skin disorders and helped lead the efforts in creating the new educational course through the American Academy of Allergy, Asthma, and Immunology titled Skin in the Game, Clinical Pearls for Contact Dermatitis, which we'll be discussing today. With that, Dr. Aquino, thank you so much for taking time to join us and welcome to the podcast.
Hello, thank you for having me.
I think that this is going to be a useful conversation. We have not addressed this topic before, so it's going to be very, very helpful for us. You know, as I was thinking about this, if we include yourself, there's seemingly just a handful of allergists that really have a strong interest in allergic skin disorders. Would you be willing to share what got you interested in this relatively niche area?
I think it was an organic process. I was always interested in drug allergy during fellowship, and so the manifestations of drug allergy being allergic skin diseases, and we had a lot of skin disease training in fellowship, I'll say. I did a lot of skin biopsies, I did a lot of patch testing, and so that got me interested in the topic. And then as my first job, I was under Dr. Fanisher, who's one of our leaders in contact allergy, and so I think it just grew from there.
As is often the case, you find a mentor early on in your career, and it kind of shapes things down the road, yes?
That's correct, yes.
Yeah. So now in your clinical practice, do you really just focus on children and adolescents that have rashes or skin disorders, or do you see patients with all types of allergic conditions?
So I primarily see children, but I still see adults in adult clinic, and I see all takers of allergy. So, food allergy, drug allergy, contact allergy, atopic derm, etc. But my sort of area of expertise is atopic derm and contact derm. So I do tend to get referred those patients more frequently.
And I have no doubt that your partners in your practice love having you so they can send you all those interesting patients.
Yes, I tend to do all the patch testing.
There you go. All right. I always like to start these conversations by having experts such as yourself just give us some basic definitions so that we're all sort of on the same page when it comes to the ensuing conversation. Can you start by just defining contact dermatitis for us?
Absolutely. So I like to think of contact dermatitis is actually divided into irritant and allergic contact dermatitis, which I know is the question you'll have coming up. But in essence, it's basically a skin condition that's caused by something that comes in contact with the skin, and which causes an inflammatory response. And then we can get into details later.
Okay, so it's pretty basic. So, cause and effect, contact with the skin, you get an ensuing, reaction there. How does that type, so this contact dermatitis, how does that differ from something like a peanut allergy? Are there different parts of the immune system that are typically involved?
Yes, typically contact allergy is what we refer to as sort of a delayed hypersensitivity. So there are definitely different cells involved in contact allergy, and the mechanisms that are involved depends whether it's irritant contact dermatitis or allergic contact dermatitis. In allergic contact dermatitis, the allergen is directly stimulating the immune system through T cells, and it can be Th2 cells, for example, and in those who are allergic to fragrance that release inflammatory mediators, which will cause the symptoms of rash. In those that have irritant contact dermatitis, a lot of the same mediators are actually released, but the mechanism is different. It's more a direct cell damage through the immune system rather than an allergic, in quotation marks, response.
So, aside from sort of those immunologic differences, what are some other differences between the irritant and allergic contact dermatitis?
So irritant is actually the most common, although we mostly focus on allergic contact when we talk about contact dermatitis. So irritant accounts for about 70 to 80%, and irritant can be caused by things that may disrupt the skin barrier, exposures in terms of pH, sometimes solvents, things that you use, even things you use to wash your hands can be irritants. So that's the most common type of contact dermatitis. Allergic contact dermatitis are allergens like metals, fragrances, preservatives. And so the allergens may be different, and sometimes what you see clinically may be different as well.
Okay. Do we know anything about the prevalence of either of these, whether it's irritant or allergic contact dermatitis among children and adults?
So yes, roughly about 15% of children and about 20% of adults, and this was from a meta-analysis that was done at the end of 2019-2020, where they looked at results of patients who were patch tested in sort of a general population. Obviously, in patients that I see that may be referred for contact allergy or patients who have atopic dermatitis, it actually may be higher than that.
Wow. I mean, so we're talking about like 1 in 5, 1 in 6 individuals in the general population. Do we know anything about certain risk factors that may make it more likely for somebody to develop either of these contact dermatitis?
Sure. And again, differentiating whether you're talking about irritant or allergic. In terms of allergic contact dermatitis or patients with atopic dermatitis are at risk. Patients in certain professions, patients who may be hairdressers, florists, chefs or food handlers, uh, even us, healthcare providers, may develop contact dermatitis, particularly dental hygienists. Allergic contact dermatitis. Those are, I would say, the biggest risk factors. Women also have a little bit of a higher risk factor than men, particularly for allergic contact dermatitis. In irritant contact dermatitis, it also may be profession dependent as well, based on your exposures that you may encounter at work.
Okay. And earlier on, you mentioned how so the contact dermatitis basically is something comes in contact with the skin and causes irritation, inflammation. But that can mean different things for different
Mhm.
people. How does contact dermatitis typically present? What kinds of symptoms should we be looking for?
Yeah, and this again will differentiate a little bit between irritant and contact, and it may differentiate a little bit between acute and chronic. So the
Mm,
most common that I think our patients or we may be familiar with is poison ivy, right? Poison ivy, poison oak, which is an acute allergic contact dermatitis, and you may see, a blistering rash that oozes and crusts, which is particularly itchy or pruritic. In someone who has maybe a more subacute or chronic allergic contact dermatitis, you may see more of what we typically look at when we look at an eczema. It may be red, it may be having that sort of scaly feel to it. In patients of skin of color, you may see maybe more hyperpigmentation than you would erythema. And so it depends a little bit if whether, as I said, it's acute, subchronic, or chronic. And typically, allergic contact dermatitis is quite itchy.
mm,
Irritant contact dermatitis may have a little bit more pain or burning, stinging sensation. And with irritant contact dermatitis, the borders may be a little bit more sharply demarcated as opposed to subacute or chronic allergic contact dermatitis.
okay. So it sounds like there's variable presentations based upon a lot of different factors. And we know that, you know better than anybody, rashes in general are just extremely common. I would garner that 100% of humans. It's a byproduct of having skin. You're going to have a rash at some point, and many times this is why people see an allergist, immunologist in the first place. So, what are some other rashes that may appear similar to contact dermatitis, and are there some easy ways to distinguish from one another?
So I think the big differential here in subacute and chronic allergic contact dermatitis is obviously atopic dermatitis. This
Mm.
may be a little bit hard to differentiate purely based on appearance because they're going to look like an eczematous dermatitis. Sometimes the location may help you, and we can talk about that in a subsequent question. But, if you have an eyelid dermatitis, maybe it's more allergic contact versus atopic dermatitis. That's the biggest, I would say, differential and the hardest to distinguish. And then you also have to keep in mind that it's not contact dermatitis is not just in the differential of atopic dermatitis. A patient with atopic dermatitis may also have coexisting contact dermatitis. So it does sometimes get a little bit difficult to distinguish just based on appearance.
Well, let's follow up on what you just mentioned. So, are there, unique areas of the body that are typically more affected by contact dermatitis? And what are some of those, and how can this serve as a clue?
So yeah, so facial dermatitis, particularly eyelid dermatitis, and if it's both upper and lower eyelids and bilateral, is very suggestive of allergic contact dermatitis. Hands and feet are areas where you can also see contact dermatitis around the mouth, so lips or perioral. And then one of them, unfortunately, one of the common patterns of contact dermatitis can also be a generalized scattered. So it can also include the torso and the abdomen.
Okay. Which is it, and how does that differ from the typical distribution of, say, atopic dermatitis, especially like in an infant or toddler?
So yeah, atopic dermatitis, based on age, you may see it more on the face in children. You may see it more on sort of the extensor surfaces as opposed to the flexural surfaces in adults and adolescents with atopic dermatitis. Again, this also may differ based on your race and ethnicity. In
Mm.
our patients with skin of color, you may see differences in atopic dermatitis. It may not seem like that, red erythema that you see typically in textbooks or in patients. You may see more of violaceous hue, and you may see more extensor surfaces and like canification in our patients of color that have atopic dermatitis.
Okay. And then how about age? Can contact dermatitis occur at any age, or should we not be thinking about this until, children are a year of age or older?
So it absolutely can occur at any age, and traditionally it was thought that it didn't occur in children.
Mm.
But there is now a lot of evidence that it can occur, particularly wipes is a big source of contact allergy that may be found in infants. But yes, we do see it in children, including toddlers.
Okay. What are some of the common causes of either allergic or irritant contact dermatitis, or both, I suppose?
So let me start with the allergic contact dermatitis. So usually within the top 10 contact allergens that are usually published by the North American Contact Dermatitis Group, and they usually publish their findings every 2 years.
Yeah.
Usually always in the top 10 are metals, and nickel remains the most common contact allergen year after year. But I will say preservatives are pretty big, including MI and MCI and other preservatives. Other common allergic contact allergens are fragrances, things like balsam of Peru, fragrance nicks, my apologies, fragrance nicks can cause contact allergy from fragrance. Sometimes even things like essential oils that may be used not purely for a fragrance uh, property can also cause fragrance allergy. So you have to have spread a wide net to catch fragrance allergy. Um, Other common contact allergens may be things that we use medically, like topical medications, bacitracin, neomycin, are common contact allergens that are medicaments. But you can also be allergic to your topical corticosteroid as well, um, from the allergen itself or from the excipients used. Those are usually within the top 10 in terms of allergic contact dermatitis. In terms of irritant contact dermatitis, I will say things that I mentioned before, things that may be acidic or very basic, things that are solvents, defattening agents, things that we use in sort of cleaning can also be irritants.
You mentioned preservatives. Tell it, like, where would we encounter preservatives? Is that in medications or just, skincare products, or what else? What
So
should we be looking for?
conservatives, are widely encountered in everyday life. Yes, they are used in sort of our topical medications, for example, but they're used in all our personal care products. They're used in our shampoos and conditioners, and they're used in our cleaning agents because they help protect the product from, going bad, from being corrupted by organisms. And so preservatives, unfortunately, are widely encountered in everyday life.
Okay. You also mentioned a word excipients. Can you tell us more about what excipients are and then how they can be sort of a hidden cause of contact dermatitis?
Absolutely. So excipients are things that may be added to a product sort of to prevent organisms from growing or to increase the shelf life or stability of the product. In terms of contact allergens, one of the big excipients that we find is propylene glycol, which is used again in topical medications and used in personal care products. It's also sometimes used as a flavoring agent, so may be encountered in foods as well.
Okay. Um, the American Contact Dermatitis Society, every year they vote for the allergen of the year. And in 2024, apparently, sulfites are on the top of the list. The allergen of the year, sulfites this year. What are sulfites? Where are they found? And why was this voted as the allergen of the year this year?
So yeah, the ACDS has the allergen of the year, and it's a big deal to be named the allergen of the year. A lot of people vote on it. It's like there's a spread in the dermatitis journal every year, so it's interesting. And some of our big players that I've mentioned have been allergen in the year in the past: nickel, propylene glycol, some of the preservatives. So in terms of this year, sulfites, a little bit of a surprising allergen in terms of contact allergen of the year. And I think the reason sort of that they chose this allergen, and if you look at the publication itself, where it was named, it was to raise awareness of sulfite allergy. And because it may not be part of your screening panel, and we are seeing increase in sort of sulfite allergy, so it's more for, I think, an awareness campaign. So what are sulfites? These are chemicals that can be used as preservatives or antioxidants. We do find them a lot in our foods and beverages, particularly wines, beers, things that dried fruits, things that may be pickled, and we do see them in pharmaceuticals and personal care products as well. As I said, they can help prevent bacterial overgrowth and they prolong the shelf life of products. So we do see them in personal care products, cosmetics. They can be in medications, household products, and in foods.
Okay. Do you participate in the voting every year, or are you not part of that group?
I do not. But we're always anxious to kind of see what got voted the allergen of the year. So I think it started off as sort of a little bit of a tongue in cheek, but it's become very popular.
Oh, that's so funny. All right, so let's say we have a patient in our office, and we suspect, or they suspect, or somebody suspected contact dermatitis. What kind of questions should we ask when we take a detailed clinical history?
Absolutely. It's a great question. So I usually like to delve into, what do they do for work is a big thing. So
Mm,
occupation. And then what do they like to do for fun? What are their hobbies? Photography, gardening, etc. Do they play an instrument? In children or adolescents, I ask about, extracurricular activities. Do they play sports? I may ask about things sort of that we do to make ourselves attractive. Do you dye your hair? Do you wear acrylic nails? Do you paint your nails? What kind of cosmetics do you use? How often do you use these cosmetics? What kind of fragrance you use. So some of those kinds of things that we use on a daily basis and things that we are exposed to through work and fun. And then I also ask about, what kind of medications they're using, particularly topical medications.
okay. Can you tell us about patch testing? Describe what that is and how that differs from traditional skin prick testing, and then how that should be used to diagnose contact dermatitis as well.
Yeah, so patch testing is what we use to diagnose allergic contact dermatitis. And unfortunately, it doesn't have the, quick response that skin prick testing does. So we don't get results that same day. And in patch testing, what we're doing is we're placing allergens on little chambers that are about the size of a fingernail and that they're fixed to the back and then staying on the back for 48 hours, so for 2 days. So it's not instant gratification with patch
Mm,
testing. And the allergens may be in a gel or they may be in aqueous or liquid form. And we place those on the back for 48 hours. We tape you up. When we take the patch test off, we're looking for induration or the skin under the positive patch to be elevated, and it can sometimes be red or erythematous.
okay. And so, how many do you just read it the one time after they come back, or do you have to read it again at a different?
No, so we read it at least 2 times. The patch is usually placed, we'll say, on day one, which is usually a Monday, and then the patient keeps the patch on for 48 hours. We usually remove the patch on day 3, and we do the initial reading at that visit. Then they come back at either day 4 or 5, so either Thursday or Friday. Personally, I prefer to have patients come back a full 48 hours later, which would be day 5, because that gives time for certain allergens to become positive or brew. And thus, there are 3 visits in 1 week. Visit 1, where the patch is placed. Visit 2, where the patch is removed and the first reading takes place. And then visit 3, where the patch is read again. Now, however, there are certain allergens that may develop late in the game. And so certain allergens like metals, topical corticosteroids, and hair dye may take a little bit longer to appear positive. In those patients where I strongly suspect, let's say, a metal allergy, I will have them come back for a third reading, and that will be day 7 to 10. So the Monday, Tuesday, or Wednesday of the week after.
Okay, yeah. So very different than our traditional types of allergy tests. It's essentially a week-long
Mhm.
commitment. Yeah.
It is a
Uh,
big commitment, and that may be sometimes why it may be difficult to do a patch test because there are some patients who may not be able to come in those 3 times in a week, may not be able to get off work. And so that is one of sort of the downsides to patch.
Are they able to bathe, shower, swim in that 5 to 7 day period?
So within the first 48 hours, I don't like them to exercise because anything that will make the patch slip
Mm,
um, may interfere with adherence, and then I may not get a good result. So in the first 48 hours, I ask them to not go to the gym or swim. They can shower, but not get their back wet. So there are some products that you can buy that you can put over the patch, by you meaning allergists who are performing the patch. Or sometimes I just tell the patients to, cover their, use a handheld shower and just keep the back dry, so especially the first 48 hours.
Okay. Let's say we have a patient, pretty classic contact dermatitis. We take a detailed history. Somebody, listened to this amazing podcast, and let's say we think we identified the most likely cause. Do we still need to do patch testing? And if so, should it just be for that suspected cause?
So I would still recommend patch testing if the patient is able to do it and you are able to do it. We don't always identify the correct allergen by history alone. There are studies that have shown that patch testing will identify the allergen sooner and improve quality of life. For those reasons, I would recommend doing patch testing. If you cannot do patch testing, then we can talk about other things that you can do based on the history that the patient provides you, trying to remove the most common contact allergens that we discussed and see if the rash or the symptoms improve. If you're going to do the patch test, unless you're looking at just a focused kind of question, is this a patient who has a metal implant and would need, that's failing, and the orthopedic surgeon wants to know, are they potentially allergic to the implant? Then I would only do metals and acrylates and topical antibiotics, things that are relevant. If I have sort of an eyelid dermatitis or generalized scattered dermatitis, then I would recommend doing a whole screening panel.
Okay. Let's play this out and say we have a patient with contact dermatitis. We do the patch testing. We think we identify the most likely cause or causes. What kind of counseling then do you offer in regards to avoidance strategies?
So yeah, the mainstay of treatment is absolutely avoidance. And again, that may depend on what the allergen is. But let's say, if it's nickel, you can cover nickel-plated objects. There are assays that you can swab, like a Q-tip swab that will turn pink with nickel exposure to kind of reduce your nickel exposure. The most practical thing that you can give your patient is a list of personal care products that are safe to use. And there are a couple of databases that are available. One is available to members of the American Contact Dermatitis Society, which I'm a member of. Another is available to other clinicians. And you place into that database what the patient is positive to. And that will take into account the positives and any cross reactors, and then it will generate a list of products safe to use, or what we call a safe list. And this will, divide the products by, shampoos and conditioners and eye makeup and mascara and cleaners for the house, detergents, etc. So it gives a list of products that are safe for the patient to use. So I think that's the most important thing to do, because avoidance can sometimes be tough by just saying, oh, you're allergic to cocamidopropylbetaine. And they're going to look at you and say, how can I look for that? And, how do I remember how to spell that? So it's a little bit difficult. So the avoidance bait and having a list of products to use that are safe to use is the mainstay of treatment.
Okay. What about this concept of ingestion of certain allergens that may cause systemic contact dermatitis? Is this something that's common, and do we need to counsel that everyone with contact dermatitis needs to watch their diet?
So it's definitely seen, and I, have had patients suffer from systemic contact dermatitis. Just to kind of define what that is, it's when you're already sensitized to an allergen, and then you may ingest the allergen in a food or a medication, or maybe inject it in the medication, and then instead of having symptoms located to your eyelid or your hands or feet, you would have symptoms on a systemic or generalized distribution. And so there are certain things that can give you systemic contact dermatitis. Nickel can be one. Some of the fragrances like Balsam of Peru. I talked about propylene glycol as well, can give you systemic contact dermatitis. Do I recommend all patients avoid ingestion? No. What I'll do is after, we have our final reading, we go over the positive allergens, I give them the safe list. We talk about other treatments like, emollients and moisturizers, and maybe sometimes using topical corticosteroids or calcineurin inhibitors to help with the areas of rash. The first thing they need to do is topical avoidance. And then when I see them back 4 to 6 weeks later, or, up to 8 weeks later for their follow-up visit after the patch, if they're not doing well, and I have one of these allergens that can potentially cause, systemic contact dermatitis, and maybe their rash is generalized, then I will recommend a 1-month trial of a Balsam of Peru diet or a low nickel diet, for example. So it's not the first thing I go to.
Okay, so you kind of have to earn that designation. That makes sense. You just touched upon this, but can you tell us more about some of the treatment options that are most useful for both acute and chronic contact dermatitis?
Yeah, there's no per se treatment that's specifically for contact dermatitis. And so some of our mainstays of treatment beyond avoidance are things that we may prescribe for patients who have rashes in general, and there's a lot of overlap in what we prescribe in patients with atopic dermatitis. So, keeping the skin moisturized and well hydrated is really important. The use of gloves or barriers sometimes is important, and types of gloves in someone who may have a hand dermatitis may be important. For itch, we will give oral antihistamines. We don't like doing, there's a topical diphenhydramine cream on the market. I would not recommend that to my patients because it does have a contact allergen in it. You're much better off treating your patients with topical corticosteroids, and then in sensitive areas like the eyelids, like a calcineurin inhibitor or a phosphodiesterase inhibitor.
Okay. And then one last question about the patch testing. You mentioned, ideally we would test for an array of allergens, make sure we're not missing anything. Sometimes we're not always, correct in our diagnosis by the history alone. Can you get false positives on patch testing? And if so, how do we know which items are necessary to avoid? I can only imagine if somebody comes back with, multiple quote unquote positives that they're avoiding everything. What can you tell us about that?
So yeah, there is something called angry back syndrome,
Mm,
um, which I think is the closest to our false positives in terms of percutaneous testing. And this is when you have a true positive patch test that's still sort of exuberant, that it makes the other allergens around it look positive. You should not remove a patch and see 5 positive allergens in the same panel.
mm,
That should be your tip off that there's something wrong. And, typically when I do patch testing, yes, I may get multiple allergens, but sometimes they're of the same class. So I may get multiple preservatives or multiple fragrances. You should not come out of patch testing. I may patch with 80. I should not see not even 10 positive allergens on patch testing. So the angry back, you suspect it when you see multiple positives right next to each other. And that is tough because then you don't know which is the true positive and which is the one that's being influenced by the true positive. So sometimes if I don't have other allergens in other locations that can give me a clue, do I have an acrylate somewhere else that's positive? Do I have a preservative somewhere else that's positive? That panel may be a wash. And at times I have repatched patients again, separating those allergens out far away from each other so that I could then distinguish what was the true positive to begin with.
okay. No, I think that was a great explanation of the sort of the expertise and understanding that's necessary to interpret these test results. Yeah, they're not like easy yes no answers, correct?
Yeah, I mean, and then I will say that when we do our workshops, both at the academy, at the college, the application of the patch is easy. Picking the patient to do the patch is easy. The hard part is the interpretation of the patch and counseling
Mm.
your patients and then determining whether the results that you got are relevant.
Hmm. Speaking of educating our colleagues on contact dermatitis, do we have any like data, whether it's survey data or objective data, that tells us if allergists in general are pretty good at diagnosing contact dermatitis, or do we have room for improvement? And then a follow-up question: do we know what percentage of practicing allergists perform their own patch testing in their practice?
So out of surveys, again, there may be some obviously bias here because providers who may be filling out the survey may be the ones that are more likely to do the service. There have been surveys by the WAO, the World Allergy Organization, and the college that have surveyed their members about how often they're doing patch testing or how many are doing patch testing. And in those surveys, it was about 50%. So it was a good number. And from their surveys, those that had either had, training or education on patch testing felt more confident in doing it. So I do think that it is an expanding practice amongst allergists. There was also another survey where they looked at billing, a study, I should say, where they looked at billing of patch testing, and they divided it amongst allergists and dermatologists. And over those 10 years, the number of allergists doing patch testing greatly increased, and there was only a very minor increase in dermatologists. So I think it is shifting where more allergists are doing patch testing. And in terms of practice management, it could be a great, revenue stream, of course, on top of being a, wonderful service that you can provide your patients.
No, absolutely. Yeah, we shouldn't be patch testing everybody that walks in the door, right?
No, absolutely not. Please, please,
Yeah.
please do not do that. I have seen providers do that. Please don't do that. Only do
Yeah.
that if you have a suspicion of contact dermatitis.
Well, let's finish and wrap things up here by talking about the new course developed for the American Academy of Allergy, Asthma, Immunology. I love the title. It's a CME course. The title is "Skin in the Game: Clinical Pearls for Contact Dermatitis." What can you tell us as to why that was developed in the first place? Is there any background that you can offer?
Absolutely. So I've been, not surprisingly involved with the Allergic Skin Disease Committee at the Academy, and I'm the current chair. And so this came out of one of our initiatives of the Contact Dermatitis Subcommittee, and we wanted to have a sort of interactional kind of course and focus on regional contact dermatitis because sometimes that may be tough. When I have someone coming in with eyelid dermatitis, what really should I be thinking about? What allergens are the most important for me to look at? And so that's where this course sort of came up. There are a lot of hours that went into it, and everyone at the Academy was great. And I have to thank all the contributors, Dr. Farmashier, Dr. Ross, Dr. Steele, Dr. Pacheco, Dr. Schur, for working on this.
This is just another example. We've had so many amazing guests over the years talk about how they get involved in committees, which leads to new ideas for either work group reports or sessions at the annual meetings or courses such as this. And our members drive the educational content that gets developed throughout the academy. And this is just another example of that. I think it's fantastic. Where can members access this curriculum, and how many hours of CME can somebody earn?
So it's 1 hour of CME total, and there are 4 sort of micro or mini courses, and it's on the educational part of the Academy website, and sort of set up in sort of micro courses where you're introduced to a patient, and we go through the workup and we discuss, the allergens that you need to look for, and then we discuss some common things that we discussed today, actually. Things like how do we treat the contact dermatitis, and what avoidance measures we should do, and what to counsel patients. So it's a very interactive course.
Okay. Lots of great pictures, I assume?
There are some very good pictures, for sure. And we tried to sort of have a picture for sort of each area that we discuss and that's relevant to the case. And so, yes, there are definitely visual cues, and there's sort of like checkpoint kind of questions, just assessing if you're, gaining some knowledge from the course.
Okay. And for our listeners, we'll put a link on our podcast landing page as well, if that's how you access this. So you can go there, and we'll directly link you right to that and the educational courses. What about cost? How much does this cost for Academy members, and is it accessible for non-members?
So in terms of whether the course is available for members or non-members, it is available for both. Members are, there is no cost associated with doing the course. For those that are non-members, there would be a nominal fee of $25, and you would need to have an account on the education website for the Academy.
Okay. All right. And you can follow all those links through the landing page as well. You have a personal interest in these allergic skin diseases and conditions. What's your call to arms for all of our colleagues to become more interested in learning more, or to take the new educational course?
So I think that it really is an important service to be able to offer your patients, and really completely evaluating them. And so I think that a lot, as you mentioned before, a lot of patients are coming in with rashes, and particularly if it's an itchy rash, they want to know what the reason is. And sometimes they think it's food, and I have to try to dissuade them of that notion. So you really want to be able to be aware of contact allergy, be aware of what the potential allergens for that patient may be, offer patch testing, improve their quality of life, offer products that they can use that are safe for them. It's just really to improve patient care. And I think you'll see in a lot of needs assessments, this is what our members need to offer their patients, because these are the patients that are coming to us.
Oh, outstanding. You've provided a wealth of knowledge for us today. I think this was extremely useful for our listeners. I encourage everybody to take the online course to learn even more. Do we miss anything in the world of contact dermatitis?
No, I think we had some pretty good talk about it. As I mentioned before, we usually have workshops both at the academy and the college for those who want to learn how to do patch testing, who may not have had a lot of exposure during training. And there is actually the journal, JACI will be having a issue on contact allergy that I wrote an article for. So if anyone is interested in contact allergy, that may be a great resource for them as well.
Dr. Aquino, thank you so much for taking time out of your schedule to join us and provide this great information. Is there anything else that you'd like to add before we depart?
No, thank you so much for the conversation, and thank you for the opportunity to talk about contact allergy.
Yeah, it was our pleasure. Thank you again. We hope you enjoyed listening to today's episode. Please visit www.AAAAI.org for show notes and any pertinent links from today's conversation. If you like the show, please take a moment to subscribe to our podcast through Apple Podcasts, Amazon, iHeartRadio, or Spotify so you can receive new episodes in the future. Thank you again for listening.